Good morning, and we are live again from the Watany Ophthalmic Summit. Today I'm going to speak with Professor Ashraf Armia. He's an ophthalmology consultant of refractive surgery and corneal surgery as well as anterior segment reconstruction. Good morning, Dr. Ashraf.
Good morning.
Okay, so you're going to talk to us today about IOLs as substitute for refractive surgery, corneal refractive surgery when it's not possible. So tell me about the options.
Yes, when there is cornea refractive surgery, it's not possible. Either it's a thin cornea or cornea irregularitis or keratoconus suspect. So in this situation, we don't do cornea refractive surgery, and we are going to choose another options like an intraocular lenses. Either we leave the original lenses of the patient and we put a secondary IOL in front of the lens. It's called the ICL. If there is no astigmatism to correct the error of refraction, or we put a toric ICL when there is a refractive error with an astigmatism, so you're going to choose the toric ICL. If it is not suitable for a secondary IOL in front of the original lens, we can change the lens, which is called refractive lens exchange. When we do a refractive lens exchange, so we make the patient early presbyopic, like he's reaching 40, he cannot read if we put a normal lens. So in this situation, we put a multifocal, either it is extended depth of focus for intermediate vision, or we put a trifocal IOLs for multi-purpose, like the near, intermediate, and distance. And we have a lot of options of trifocal IOLs. Also, there is a bifocal IOLs, which is for the intermediate and far. And we have a new lenses called Enhance. It's give the depth of focus. It's not a multifocal, but it gives a depth of focus that helps the patient for near work. This is the most important options, but to do this, the ocular surface of the patient, like the dry eye or the status of the lids, must be in a very good state, because to choose the power of this lens, you must have an ocular surface to be in a good state.
Okay, so you're saying that refractive lens exchange is more critical than ICL implantation.
This is true,
okay.
Because when we remove the lens, we make the vitreous movement, and this can cause some problems in the retina if there is no PVD, and the vitreous can tract on the periphery of the retina, and if there is some suspicious holes in the periphery, it can lead to a retinal tear, lead to retinal detachment, or sometimes in some patient there is hidden taut epiretinal membrane that can lead to cystoid macular edema in these patients, which is common postoperatively in the first 2 to 3 weeks postoperatively. So this is not it is not as easy operation to do it.
I see. Okay, so with all the developments right now, with all the technologies available on the market, can you tell us about patient selection? Which patients do you select for either techniques?
Yes. If we are going to do a refractive lens exchange for the patient above 40, so we are aiming to correct the distance and the near for the patient, because if we correct the distance for the patient and we make him disabled to read the near objects, so we should put a multifocal IOLs to make the patient lifestyle easy. Also, some patients need an intermediate vision, which is his or her work, like computers, about 30 to 40 centimeters. So in this type of patient, we can choose, instead of multifocal IOLs, we can put an extended depth of focus, which is the more suitable than the multifocal for this patient. So according to how to talk to the patient, how to select the proper, how his work, his lifestyle, we can choose the premium best IOL for the patient.
Okay, and what about the toric IOLs again, patient selection, on which patient you use a toric IOL or go for any other option?
Yes.
Tell me about patient consultation and patient selection for
Excellent.
the
Very, very good question, because astigmatism, more than one, in cases of we are going to implant multifocal IOLs, if we leave the astigmatism not corrected, the patient will not go to be happy by the multifocal. Because astigmatism, it, distortion of vision, so he's going to see but with no contrast. So if we do this premium IOLs, we should correct the refractive error and the astigmatism. If we didn't do this either, we do it on the cornea, we do a normal IOL in the eye, and the residual we do it in the cornea. It's called the bioptics. That we do a premium cut with the femto LASIK first, and we don't elevate it. Then we implant the IOL, and the second day we see the residual, and we elevate the flap, correct the residual, and we make the patient nearly 6 postoperatively for distance and for reading also. This is the perfect way to correct the vision in patient nowadays, because every patient nowadays needs the best vision for near and for distance also.
Okay, this is very interesting, because what you're saying is that for bioptics you need longer time. You need the patient to be, coming back for another surgery the next day, so it might not be an option for a patient coming from far, right?
Yes, because in these cases with the high refractive errors, the biometry, which is the calculation of the IOL, usually there's some errors. We must tell the patient in the premium IOLs that we may need a touch-up laser post-operatively. He must be ready for this. Any premium IOLs, we should tell the patient we are going to do the best now, but if there is any residual refractive error, we are going to have a touch of laser post-operatively in the first week or 2 weeks post-operatively.
Okay, very good. And last question, because you mentioned ocular surface disease, what is your preferred practice? If you find that the cornea is not up to satisfactory levels, would you recommend that you keep the patient on lubricants and bring them back for reassessment? What is your preferred practice?
Yes, this is the very important ocular surface disease, which is the main issue nowadays because of the computer time of the patient, the humidity, the change of the climate. Most of the
and these are probably contact lens wearers.
Contact lens wearers. This is the main issues nowadays, and we should treat the ocular surface disease first and the dry of the patient, either by lubricant, either by substitute for lipids, either by massage with ultrasound, either by expression of the closed meibomian glands. In a good way, you leave the patient fit for calculation of the IOL. Never go for a premium IOL and you have a dry eye. It will be wrong, and the patient, you are not going to have a satisfied patient ever.
Right. Thank you very much, Dr. Armia, for your time.
Thank you so much.
And that concludes our...
Thank you so much.